You know that familiar, just stubborn ache, maybe deep in your buttock, sometimes shooting down your leg. It can be incredibly frustrating and honestly pretty confusing to figure out what's actually going on. Is it just a pulled muscle? Or, something more. It's such a common thing people deal with, and nailing down the real cause. That often feels like trying to solve a puzzle with half the pieces missing. Well, today on the Deep Dive, our mission is to cut through some of that confusion. We're diving into two conditions that get mixed up all the time because, well, the symptoms feel so similar, sciatica and piriformis syndrome. They can both make sitting pretty miserable, but where they come from, how doctors figure them out, and importantly, how you treat them effectively, that's where they really differ. Our goal here is to give you some clarity, that crystal clear understanding so you can maybe figure out what's happening with your own body or understand what someone you know is going through. We've pulled together insights from, detailed medical presentations, research, basically distilling the complex stuff into knowledge you can actually use. So let's jump right in. We're talking about two different starting points for pain that can feel, well, remarkably alike. Fundamentally, we're drawing a line here, right, between issues rooted in your spine versus problems linked more to muscle dysfunction.
That's a great way to put it.
It's almost like, is the signal bad at the main switchboard, or is something squeezing the wire further down?
Exactly. That's a critical distinction to make right up front. So when we talk about sciatica, proper sciatica, we mean pain that follows the path of that big sciatic nerve. And this nerve, it's quite a long one. Starts in your lower back, weaves through your hips and buttocks, and then runs down each leg. The key thing about sciatica is that the cause is typically compression of the nerve right at its root. So something structural in your spine is pinching it.
Okay.
Think like a herniated disc, maybe a bone spur growing where it shouldn't, or spinal stenosis, which is a narrowing of the spinal canal itself. The problem really starts in the spine.
Right, so a core structural issue, a direct pinch from bone, or a slipped disc in the spine. That makes sense. But then how does piriformis syndrome manage to cause such similar pain if it's just a muscle issue? It seems, less direct than a spinal problem.
Yeah, it's a really good question, and it gets to the heart of the confusion. With piriformis syndrome, the sciatic nerve is still getting compressed or irritated, absolutely. But the problem isn't coming from the spine this time. The culprit is actually the piriformis muscle itself.
Ah, okay.
It's a relatively small muscle tucked deep in your buttock, helps rotate your hip outwards. Piriformis syndrome happens when this muscle spasms or gets really tight, maybe inflamed, and because the sciatic nerve often runs right underneath it, or sometimes, interestingly, even through the muscle fibers in some people, that tight muscle physically squeezes the nerve.
Wow. Okay.
Similar feeling pain, maybe, but the cause isn't spinal structure. It's a misbehaving muscle, often linked to things like muscle imbalances, overuse, think runners or cyclists, or even a direct hit or fall onto the buttock.
That really clarifies it. One's like a structural pinch from the spine's bony setup. The other's more of a soft tissue squeeze from a muscle having a bad day. Understanding what's doing the squeezing seems like, well, half the battle, doesn't it? Because it tells you where to even start looking for a fix.
Exactly. And it's fascinating how these very different locations and mechanisms of compression can produce symptoms that feel almost identical to the person experiencing them. But let's dig a bit deeper into those specific causes, because that really highlights how different they are. For sciatica, like we said, it's all about spinal health. A really common one is a herniated disc. Where the soft, gel-like center of a spinal disc pushes out through a tear in its tougher outer layer.
Yeah, the jelly donut analogy.
Right. That jelly squishes out and compresses directly on the sciatic nerve root.
Ouch. Yeah, I can picture that vividly. So it's literally a bulging cushion in the spine. What about the other spinal causes?
Well, another major one is spinal stenosis. This is basically a narrowing of the spaces within your spine. Often happens as we age, just wear and tear. This narrowing can put pressure on the spinal cord itself, and importantly, on the nerve roots branching off, including those sciatic nerve roots. Think of it like a tunnel slowly getting tighter.
Okay, restricting the space.
Yep. And then you have bone spurs. These are little bony growths, osteophytes, that can form along the edges of bones, especially in joints. If they develop on your vertebrae, they can physically grow into the space where the nerves exit and compress them, leading to that sciatic pain.
So all fundamentally about the spine's structure and integrity. That makes it clear how our back's architecture can directly cause nerve pain. But with piriformis syndrome, the story shifts completely to the muscle, right? Instead of bone spurs or discs, what makes that specific muscle get so tight or angry?
Right, the focus moves entirely to the muscle. A very common factor is muscle imbalance or overuse. So activities that repeatedly work, stress, or shorten that piriformis muscle without enough counter-stretching or balancing work for the surrounding muscles, that can lead it to get tight, prone to spasms.
Like endurance athletes.
Exactly. Runners, cyclists, their piriformis is working hard. If it's overworked, or maybe the other hip muscles, like the glutes, aren't strong enough to help out properly, the piriformis can end up taking too much strain and becoming dysfunctional.
I can definitely see that. I remember once overdoing it with some new exercises, and my glutes felt, well, like they were protesting loudly for days. Is it that kind of scenario, just with the added nerve pinch?
Very similar principle, yes. Just add nerve irritation to the mix.
Yeah.
Then there's trauma. A direct fall onto the buttock, a hard hit in that area. That can cause localized swelling, inflammation, maybe even some scar tissue forming within the piriformis muscle itself. And that injury response can directly aggravate the nearby sciatic nerve.
Makes sense. A direct injury.
And finally, there's this interesting anatomical point. Anatomical variations. For some people, just naturally, their sciatic nerve actually passes through the piriformis muscle fibers instead of neatly underneath it.
Really? Through it?
Yes, which means they're inherently more susceptible to nerve compression whenever that piriformis muscle tightens up, even a little bit. It's like they're anatomically predisposed.
Wow, that's fascinating. The nerve literally weaving through the muscle. That really explains why for some folks this might be a recurring battle no matter how careful they are. Okay, so we've got spinal architecture issues, we've got muscular problems from overuse or injury, and even these unique anatomical setups. This brings us to, I think, a really crucial point for anyone listening, the symptoms. Because those subtle differences, where the pain starts, how severe the tingling is, those are the clues that help unlock the mystery, right?
They absolutely are. How the pain presents, its specific character, where it's located, that's incredibly valuable information. For sciatica, the hallmark symptom is that radiating pain. It typically follows the path of the sciatic nerve quite clearly, starts low back, goes through the buttock, down into the leg, sometimes all the way to the foot.
The full journey.
The full journey. And it's usually not just pain. It often comes with those classic nerve sensations. Numbness, tingling, pins and needles, sometimes even noticeable muscle weakness in that leg or foot. And often a key point is that the leg pain itself is frequently more severe, more dominant than any actual lower back pain.
Ah, okay. So it's not just a backache spilling over. It's a primary, often quite intense leg issue, usually with those nerve feelings. That seems like a big flag.
It really is. And because it's a nerve root problem right at the spine, true sciatica is much more likely to cause significant neurological signs. You might find it hard to lift your toes or stand on your heel because of pronounced numbness or weakness, things that aggravate it. Prolonged sitting is a classic one. Or activities that tension the nerve, like trying to lift the straight leg that can really set it off. It's the kind of pain that makes finding a comfortable position really hard.
Right, constantly shifting. Okay, so a clear path, often intense leg pain, and those definite nerve signs pointing to a bigger neurological impact. How does piriformis syndrome compare symptom-wise? How does its pain tell a different story?
It's often quite different in its presentation. With piriformis syndrome, the pain typically starts more locally, right in the buttock itself, rather than clearly originating in the lower back.
Okay, the starting point is key.
Very key. While the pain can radiate down the leg, it tends to be more focused or concentrated in the buttock area. The intensity down the leg is usually less severe and maybe doesn't travel as far down compared to classic sciatica. That deep ache or tenderness right in the buttock. That's often the main complaint. You might feel it gets worse if you press on that specific piriformis muscle spot.
So the epicenter is more the glute area, and the leg part is maybe less dramatic or widespread. That helps narrow things down a lot.
Precisely.
Yeah.
And while you can get numbness or tingling with piriformis syndrome, it's generally less severe, less extensive. It might feel more localized, maybe just the back of the thigh or calf, but usually doesn't involve the whole foot with that profound numbness you can get with severe sciatica. The neurological impact tends to be milder.
Similar to sciatica, though, prolonged sitting, especially on hard surfaces, can definitely make it worse, as can activities that directly engage or irritate the piriformis, like certain hip movements, rotation, or running. But the main differentiator often comes back to that initial location, buttock, versus low back leg, and the degree of those neurological symptoms down the leg.
It's those nuances, isn't it?
Yeah.
Where it starts, how intense the nerve stuff feels, which leads us perfectly into diagnosis. Because getting the right diagnosis isn't just about having a name for it. It's about avoiding potentially months or even years of treatments that just aren't hitting the mark. Imagine getting spinal treatments when the issue is purely muscular, or vice versa.
Absolutely.
These diagnostic tests, they're not just medical procedures. They're potentially your fastest path to actually feeling better, aren't they? Couldn't agree more. Without pinpointing the cause accurately, treatment becomes guesswork, which is frustrating and inefficient for everyone involved. That's why a good physical exam with specific tests is so vital. We generally rely on a couple of key tests in the clinic to help tell these two apart. The first one is the straight leg raise test.
Okay, the straight leg raise, how does that work and what's it telling the clinician?
So for this test, you'd be lying flat on your back. The clinician slowly and carefully lifts your affected leg straight up towards the ceiling, keeping the knee straight. Now, if doing that triggers your typical pain, especially radiating down the leg, somewhere between about 30 and 70 degrees of hip flexion, that's a strong positive sign for a nerve root issue in the spine.
Why that specific range?
Because that range specifically puts gentle tension on the sciatic nerve and its roots back in the lumbar spine. If they're already irritated or compressed there, this movement will reproduce the symptoms. So a positive test strongly suggests sciatica. And here's the crucial part for differentiation. This test often does not reproduce the main symptoms of piriformis syndrome. If the piriformis muscle is the problem, just lifting the leg straight up might not cause much pain or maybe just a local stretch feeling.
Got it. So positive SLR points towards the spine. That's a really helpful differentiator. So what's the go-to test if you suspect the piriformis muscle instead?
That would likely be the FAIR test. FAIR is an acronym: flexion, adduction, and internal rotation.
Okay, fair test. What's involved there?
So during this test, again, usually lying down, the clinician will carefully move your hip into that specific combination of positions. Bent up towards your chest, flexion, brought across the midline of your body, adduction, and then gently twisted inward, internal rotation. If this specific maneuver reproduces your pain, particularly that deep pain right in the buttock area, that's a strong indicator that it's the piriformis muscle being stretched or compressed and irritating the sciatic nerve as it passes by or through it.
So you're directly provoking the muscle suspected of causing the issue.
Exactly. This test is designed to put the piriformis in a position of stretch and potential compression against the nerve, mimicking how it might get irritated during certain movements.
That's incredibly smart, actually. You're either tensioning the nerve from its root with the SLR, or you're specifically targeting the piriformis muscle with the FAIR test. It really shows how targeted diagnostics need to be, like having two different keys for locks that look almost the same from the outside.
That's a perfect analogy. These tests, combined of course with listening carefully to your symptoms and history, allow us to move beyond just guessing and really hone in on the likely cause.
Which, naturally, leads us straight into treatment, and specifically physical therapy. Because as we've established, the diagnosis dictates the treatment entirely. You wouldn't use the same approach for a spinal nerve root issue as you would for a tight muscle, even if the pain feels confusingly similar. So let's talk about how PT management is tailored. What are the goals for someone with true sciatica?
Right, the goals are fundamentally different because the underlying problem is different. For sciatica, the main focus of PT is addressing that spinal issue causing the nerve compression. So the primary goals are things like decompressing the affected nerve root, finding ways to take pressure off it, stabilizing the lower back and pelvis to provide better structural support, and improving the way the spine moves overall to reduce irritation on the nerve where it exits.
Okay, so it's all about fixing the spinal mechanics, relieving pressure there, and supporting the structure. What kind of methods do therapists use to achieve that for sciatica?
There are several common approaches. One well-known one is the McKenzie method, or MDT. This involves specific, repeated movements, often into extension, bending backwards, or sometimes flexion, bending forwards, depending on what helps. The aim is often to achieve centralization of pain. That means the pain that was radiating far down your leg starts to retreat, moving closer toward your lower back. If your leg pain reduces and becomes more focused in the back, that's usually a very good sign the nerve pressure is easing.
Centralization. Okay, makes sense.
Then there are nerve glides, or neuromobilization exercises. These are gentle, specific movements designed to help the sciatic nerve slide and glide more freely along its path from the spine down the leg. Helps prevent it from getting stuck or irritated by surrounding structures.
Like flossing the nerve.
Kind of, yeah. And core stabilization is huge. Exercises like planks, bird dogs, bridges, they strengthen those deep core muscles, the abdominals and back extensors, which act like a natural corset to support the spine. We also encourage low-impact aerobic exercise, walking, swimming, stationary bike. It improves blood flow, which helps healing and can reduce inflammation. And finally, manual therapy. This is hands-on work from the therapist, maybe joint mobilizations or manipulations, aimed at improving movement in specific spinal segments that might be stiff or restricted.
That sounds really comprehensive for sciatica, targeting the spine from multiple angles. Now, shifting gears to piriformis syndrome. Since the problem is the muscle, I'm guessing the PT goals and methods look quite different, less focus on the spine itself.
Totally different focus. For piriformis syndrome, PT zeroes in on the hip and the gluteal muscles. The main goals become reducing the tightness and spasm, specifically in the piriformis muscle, strengthening the other hip muscles, the glutes, the abductors, so they can support the hip properly and take the load off the piriformis, and promoting better movement patterns for the whole hip and pelvis complex.
So stretching that tight piriformis and then strengthening its neighbors seems key. What does that look like in practice?
Exactly. Stretching is absolutely central. There are very specific stretches targeting the piriformis, like the figure 4 stretch lying on your back, or variations of the pigeon pose from yoga. These aim to lengthen that tight muscle.
I think I know those.
Yeah, they're common for a reason. Manual therapy is also very important here, but focused on the muscle. Techniques like deep tissue massage directly on the piriformis, trigger point release to break up knots, or myofascial release to address tightness in the surrounding connective tissue.
Hands-on work on the muscle itself.
Right. Then strengthening, but not the piriformis, usually.
Right.
We focus on strengthening the muscles around it, particularly the hip abductors, muscles on the outside of the hip, and the other gluteal muscles, things like clamshell exercises, side leg raises, glute bridges. The idea is to improve stability and control around the hip so the piriformis doesn't have to overwork.
Building up the support crew.
Precisely. Heat or cold therapy applied to the buttock can also be helpful symptomatically, reducing spasm and inflammation. And interestingly, nerve glides are sometimes used here too.
Oh, for piriformis as well?
Yes, but the rationale is slightly different. Here, the nerve glide is helping the sciatic nerve move more freely past or through the potentially tight piriformis muscle itself, rather than freeing it from spinal compression. Same technique, slightly different target area causing the restriction.
That's a really critical distinction for the nerve glides. Same exercise, but adjusting a different pinch point. It just underscores how vital that correct diagnosis is. You can't just do generic back exercises or hip stretches and hope for the best if you don't know if the problem is bone or muscle, spine, or hip.
Indeed. It really highlights that effective care needs to be personalized and precise based on a clear understanding of the underlying cause.
And that, everyone listening, brings us towards the end of our deep dive today. We've really unpacked the crucial differences between sciatica and piriformis syndrome. We started by getting clear on that fundamental distinction. One originates in the spine, the other involves muscle dysfunction in the butt. We looked at their specific causes: herniated discs, stenosis, bone spurs for sciatica versus muscle overuse, trauma, even those anatomical quirks for piriformis syndrome. We explored how their symptoms, while overlapping, often have subtle but key differences, especially where the pain starts and how far and intensely it radiates, plus the degree of those nerve sensations.
Absolutely, those details matter.
Then we learned about the specific diagnostic tools, like the straight leg raise pointing to the spine and the FAIR test pointing towards the piriformis. And finally, how physical therapy needs to be completely tailored, focusing on spinal decompression and stability for sciatica versus muscle release and hip strengthening for piriformis syndrome. What this journey through the information really shows is just how critical understanding these distinctions is. It's not just academic, it's essential for getting the right diagnosis and therefore the right treatment.
It saves so much time and frustration.
Definitely. Knowing why you have pain, down to the specific cause, truly changes everything about how you approach finding relief. It moves you from confusion to clarity. So maybe the final thought for you to consider is this. Next time you, or someone you know, feels that ache, think beyond just where it hurts. Consider what might actually be causing it deep down. How much more empowered are we when we can understand and articulate what's happening inside our own bodies? When we can advocate for the right kind of investigation and care based on real understanding? This knowledge isn't just interesting information. It's genuinely your first step towards taking control, finding true relief, and navigating your own health journey more effectively. We really hope this deep dive has helped bring some of that clarity to you today.